Afternoon to everybody. I'm Anu Sharma. I'm pursuing my PhD in ophthalmology in Dr. R.P. Center in Retinal Services under Professor Atul Kumar, sir.
Okay. Thank you so much for that, and we invite you for your guest talk.
Thank you very much, sir, for giving me the opportunity to speak on the topic adaptive optics. So, as the name indicates, it incorporates the optics which adapts to the optical aberrations of the optical segments of the eye. Now we all know there are many high order and low order aberrations in the eye because of the cornea and the lens, such as coma, trefoil and distortions. So the aberrations not only cause blur image on the retina but also cause the images of the retina for the camera. So the principle is, again, it improves the lateral resolution with the help of its components. And the lateral resolution is improved to 2 to 3 microns. As we all know, there is an improvement in the axial resolution in the OCTs, especially the SS OCT. So here I am going to discuss the flood illumination AO retinal camera, that is the RTX1 Eyes, Orsay, France. There is one more type of retinal camera which is available, that is based on SLO technology. So this is the view of the retinal camera which we use in our RP center. So there are 4 components. One is a wavefront sensor which measures the aberrations, and the next is the correcting elements which constantly reshapes to correct the aberrations, and with the CCD camera and with the computer algorithms, it removes the aberrations to obtain a high resolution retinal images. The optics is depicted here. So the wavelength of the device is 750 nanometer, and there is another source of light at 850 nanometer which illuminates the retina and gives the optical map of area 4 by 4 degrees of arc. There is a yellow cross in the center for the fixation, and a real-time display with a video camera is present to monitor the fixation. The image acquisition is done with the CCD camera, and it requires a pupillary dilatation with the spherical equivalent error which is being fed in the machine. 40 images are required in 4 seconds, and it can be done at 0, 2 and 4 and even 6 degrees eccentricity along the horizontal and the vertical meridians. The depth can be altered from 80 to 200 microns depending upon the area of interest. The photoreceptors are imaged at 80 microns depth, whereas the retinal vessels are imaged at 200 microns depth. Now coming on to the applications, here the photoreceptor cell density and the spacing with the mosaic regularity is seen in vivo, along with the RPE and retinal vessels. Also the lamina cribrosa can be seen beautifully with the machine. Now here they are seeing, it will take some time. Okay, it will be seen in the subsequent slides also. Here we are seeing the photoreceptors on the left hand side and the retinal vessels with the lumen and the wall diameter on the right hand side. The analysis of the image is done with the computer algorithm along with the deformable mirror. So there is a AO detect software which processes and gives the density per mm square. So the normative data values have been quite varied in many studies, and still many studies have to be done in Indian population. Now this is the n-fast reflectance image of the photoreceptor. Actually the center of the map is blurred. That is because the very high density of photoreceptor at the fovea, so the machine is not able to resolve, and the density decreases as the eccentricity increases. So these are the VORONOI tessellation of the photoreceptors, where the green are considered to be normal, having the hexagonal structure, and therefore 6 to 7 neighboring cells. So if the geometry of the photoreceptor is altered, the neighboring cell would be less. This is the normal report which we get for the normal individual. I am going to show few multimodality imaging of few retinal diseases with AO mapping. This is the case of the myopic CNVM, where the CNV has developed in the along the Lacquer crack. This is the FFA and ICGA imaging of 45-degree field along with the OCTA, which also gives us the 45-degree field. And below is the AO imaging of 4x4 degree arc, where the striations are clearly seen. Here the photoreceptor mosaic is disrupted and it's not normal. There are many hyperreflective areas and hyporeflective areas. This is the case of the neovascular AMD, in which there are a lot of intraretinal fluid. Below is the autofluorescence of the same patient and the OCTA. This is beautifully seen on Angioplex Zeiss camera. This is the AO imaging. Again, the NFAS image is quite blurred with various hyporeflective areas which show the atrophy. On the right hand side are the VARANOI tiles, in which there is just one green colored photoreceptor and the number of blues and yellows are more. So this is the case of crystalline dystrophy. This is the multimodal imaging B scan, OCTA, and this is the AO map, in which the density is reduced from around 30,000 cells per mm square to 20 in the right and in the OD, and 17,000, around 70,000 in the left eye. This is the case of the cone dystrophy, in which the amplitude has reduced and latency has increased in the mfERG, and the AO mapping, which clearly shows abnormal photoreceptor geometry, and reflectance is also altered. There are many hypo and hyperreflective areas with absolutely no visualization of hexagonal cones. Again, this is the VORONOI tessellation. This is a case of multimodal imaging of macular hole. As clearly seen, there is a lot of loss of photoreceptors right at the macular hole. And this is a post-op 1 month imaging of the same patient, where we are seeing the rearrangement of the photoreceptors. This is the case of the multimodality imaging of toxoplasmosis. And here is the AO mapping done. The left hand side is the margin of the toxo scar, and the center is the central scar is depicted in the right hand side, where there is again no visualization of hexagon cone structure. Now this is the AO mapping of retinal vessels, where we can see the AO map of the lumen and the wall, which can help in the in understanding of the microvascular changes in diabetic retinopathies and hypertensive retinopathies. The capillary bend can also be beautifully visualized in adaptive optics. Now, should we consider it only as a research tool? It aids in the detection of early signs of the disease, and it provides the new information about pathological changes with disease progression. It can help in the monitoring of treatment efficacy at the cellular level, and benefits various clinical trials by accelerating documentation of the treatments. Thank you.
Thank you very much for the very informative talk, and being a guest lecture, so we can't ask cross questions. Sorry for that. Otherwise we could have had a fruitful discussion. With this, thank you once again for your kind presentation. We move on to the next presenter, Dr. Vineet Mutha.
Okay. Thank you very much, sir.
Thanks. On OCT guided PD